to AfroDX. Today it's a clinical unknown case, and it was prepared by Sebastian, and today I'll be the presenter, and the discussant is our beloved chief, Dr. Joseph. So today, the introduction, we are having a 65 years old female with headache for 3 years. So I think Joseph, you can start from here, but I think it's gonna be a very long discussion. So since we have done several presentations on headache, so I think you can just be brief here, then I can take you through the HPI. Welcome, Joseph.
Thank you, Roland, and thank you very much for taking the time presenting today so that we don't hear the same voices over and over every time.
Yes.
The 3 years history plus the age of the patient, who is 65-year-old female. And we say if you have headache, you say maybe it's primary or secondary. More likely at 65, it has to be secondary, but a very small percent of primary headaches can start in old age, especially in females. So that's what I'll be doing, is trying to figure out, is this a primary headache or a secondary headache? Thank you. And let's proceed with the HPI.
Okay. So this headache was for 3 years. It was gradual onset, generalized. It was dull in nature. The patient was having 2 to 3 episodes a week. They were lasting about 3 to 4 hours. And the pain score of this patient was 2 to 3. It was not interfering with her daily activities, but rarely requiring painkillers. It was not associated with sleepiness, mood change, increased sensitivity to light, sound or movement, or eye redness and tearing. However, 2 months ago, the patient experienced a change in headache pattern, had a crashing headache that woke up from her sleep. It was generalized, not radiating to the neck. It was maximum within minutes, and it was described as the worst in her life. It was not relieved with anti-pain injection, which was given at a local hospital, and slowly it was decreasing over a week to moderate pain that required daily painkillers with relief, not aggravated by lying flat, straining, or coughing. It was associated with loss of vision, which was of sudden onset, started in the left eye within 2 hours of headache onset, and there was complete and persistent loss of vision, which was associated with swelling of the left eye. This was progressive, and the right eye vision started to decrease in 24 hours. It started from blurry to complete vision loss in the next 2 days. And the right eye started to improve vision slightly after 2 weeks, but could not walk without support. And the above symptom of reduced eyesight, it was not associated with flutters or flashes, no halos around the right, no pain on eye movement, no eye protrusion, nausea, vomiting, no unilateral limb weakness, and there was no change in speech, neither were there conversions. Same, there was no unilateral limb weakness and change in speech, no fever, and no neck pain. There was no history of change in body weight, change in appetite, or constipation or diarrhea, cold or heat intolerance. There was no unprovoked fracture. There was no increased hand or feet size or need to increase the ring size. There was no history of voice hoarseness, excessive sweating, awareness of heartbeat, lower limb swelling, nipple discharge, excessive urination or thirst, and dizziness or fainting. Neither there was history of knocking objects while she's walking, or inability to see on the sides, need for spectacles, and previous eye surgery or trauma. Neither were there history of illicit drug use, cigarette smoking, or alcohol consumption, and use of antidepressant drugs, and similar familiar presentation. So this is the HPI, Joseph. It's long, but I truly believe that you have caught up some stuffs which you can continue from here. So you're warmly welcome, Chief.
Yeah. Um, thank you very much. So I think this is a bit tough one because, as you're saying, uh, long history. So let me try to like separate the useful information from the non-useful information for what I would think would be important to arrive at the diagnosis. So we started saying a 3 years, it's 3 years history headache that was there, and my job was to figure out is this secondary or primary. The easier way to think and say maybe it was primary until I think 2 months ago, and then it changed to be a secondary because the next headache, the 2 months headache, which lead to, to the point that we are seeing the patient came because of this 2 months history headache. The 3 years, like 2.8 years, patient was just sitting there at home. But again, maybe that's the case. But once you say headache at 3 years, it means this patient is 65. So even that 3 years headache started at 62. And chances are it has to be a secondary headache. But as I said, not 100%. And then we go back. If we say maybe it was a primary headache, what do we think? So mostly we think of migraine headache, which we all know. Uh, doesn't fit the history that was being presented, that the 2 to 3 severity of headache that was there for 2 point something years. Does it fit migraine? The does it fit the tension headache? um, maybe it's tension headache, but again, tension headache is 62 years, less likely. At least migraine, there's a percent there, I know, starting elderly females. And then you have this other group, I think is called I think trigeminal neuralgiform headache, which is 5 categories of headache, in that including cluster, which you all know, but there are others, sunk, tsuna, maybe intermittent headaches in that sort. But I think it's not keeping up with that group because, as we are told, there is no autonomic symptoms, there's no eye reddening or tearing. So if I say it was primary headache, I can miss stuff. If I think this was secondary headache since back then, and then now maybe something has changed, I think I can have this miss. And as you all know, before you diagnose any primary headache, you have to do imaging so that you rule out the secondary, because history alone is not enough. So we assume we are dealing with a 3 years secondary headache. There's something was causing it, and then now, 2 months ago, this everything has changed. Something else came up. So it's so hard to think what was that, but it's easier if I start with the history of 2 months ago. And what I'm seeing here is I picked some things that this was the headache, which is the worst of life. Patient says, this is the headache worst of life. And the way it starts within minutes, it goes to the maximum. Now this is the thunderclap headache. And once you say thunderclap headache, if you type that in your Google, it's a problem now. I think over these 2 months, what started over these 2 months is a thunderclap headache. And for me, if I think of a thunderclap headache, there are several diagnoses, but whatever you get at the end, you shouldn't miss two most common, which are one, a subarachnoid hemorrhage, and the other is RCVS. I think the long form of it is um, reversible cerebral vasoconstriction syndrome. So you shouldn't miss that. There are other causes that I think I'll be recalling them maybe later, but it'll be hard for me to read them, but I'll try. And if I think on the part, maybe this subarachnoid hemorrhage that occurred back then, it, the 3-year headache will make more sense because uh, subarachnoid hemorrhage might start from an an aneurysm which was there growing slowly, sitting there, causing minimal headache. Some aneurysm are not even symptomatic. Someone can present with subarachnoid hemorrhage and they just had an aneurysm which was asymptomatic, but it can be symptomatic like this. And then the another is the RCVS. I think RCVS is more of in these young patients than old ones. Do I have any other differential diagnosis regarding this thundercrap headache? I think yes, mostly will be still vascular. And for example, you can have PRESS. You can have PRESS, for example, posterior reversible encephalopathy syndrome. And you have all seen this if you see a patient with a pregnant women who have a severe preeclampsia, they come in with very bad headache and they have press. If you usually don't image them, but if you image them, you will see they have findings on the posterior part of their brain. A worst headache can come with a hemorrhagic stroke also. So also that should be considered at the end. If I have some, I think there are some, but I think I'll see how the history turns out to be, and maybe I change from this. But two, I must consider the most common: RCVS plus subarachnoid hemorrhage, and with the 3-year history, maybe it was an aneurysm and then it has ruptured now. But again, we are told this patient lost vision. So, Roland, can I see that part because it was fast there? Yeah. Yeah, so we're told there is a loss of vision, which makes this diagnosis to be a secondary headache more and more. So a sudden loss of vision, which started within 2 hours of headache, complete and persistent loss of vision, swelling around the left eye. Okay, so things which happen abruptly in medicine, they're usually, apart from accidents, they're usually maybe coming from two mechanisms. One is electricity, and two is blood vessels. Electricity meaning that a heart attack, for example, is an electrical. An arrhythmia, for example, is an electrical phenomenon, and a seizure is an electrical phenomenon. But others are usually blood vessel related, a heart attack, a stroke, and here we're told sudden loss of vision, and you say maybe also this is a vascular in origin, but this is not just loss of vision. It's a loss of vision associated with swelling around the eye that is losing vision. But to approach it systematically, you can think of the structures of the eye, and you have the globe with all the structures that you know from front to the back. In the back of the eye, you have the cranial nerve number 2, which sends the information, and from there you have the brain back there. And you think, what structures can lose vision suddenly, like acutely, like this? And you don't have much, because think of the cornea. Someone who have a corneal opacity is not something which happens that much quickly. A retina is possible, so maybe we have a sudden, maybe a stroke of the retinal artery, for example. So that will be the case. Again, what I'm seeing here is, I think the after one eye, it went to another eye. That the right eye also progressive right eye vision started to decrease in 24 hours. Yes, so it also involved the right eye, but I'm not understanding something here that the right eye started to improve slightly after 2 weeks, but could not walk without support. Even the patient could not walk without support, like there was weakness. Laurent.
Joseph, can you hear me?
Yes, I can hear you. I'm saying patient could not work without support because of vision or because they didn't have weakness, I think, right?
Yes, she didn't have weakness.
Okay, thank you. So I'm trying to figure out uh, um, what what disease now can cause vision loss like this with the eye swelling, and not much that I can figure out. But one thing to remember, and this is is common, a patient who has headaches, a patient above 50 who has headaches and then they lose vision, you should also think of diagnosis of GCA, a giant cell arteritis, but it doesn't look like this at all. Giant cell arteritis is it's usually a painless loss of vision, usually unilateral, and the headache is like characteristic. It is not the GCA headache. It is not a thundercrap headache. So yeah, I can't connect it right now. Maybe as we proceed, I'll figure out some stuff, Roland. I think we should proceed.
Okay, thank you, Joseph. That is such an incredible start, you know. So the review of other system was remarkable. Her past medical history and the patient, she happens to be hypertensive since 2021, which is well controlled on drugs, amlodipine. And on her general examination, she was conscious, febrile, with no moon face. She was not pale, not jaundice, and not cyanosed. She had bilateral xanthelasma. She was not dehydrated, no angular stomatitis, no oral thrush, no petechi, no ecchymosis, no palpable peripheral lymph nodes, and there was no lower limb edema. This patient didn't have a stigmatas of chronic liver or kidney disease. Vitals, the respiratory rate was at 18 cycles per minute, saturating at 98% on ambient air, and the temperature being 37.1 degrees Celsius. Her blood pressure systolic was 138 and diastolic of 82, pulse rate being at 80 beats per minute, and body mass index was at 31.1 kilogram per meter square, and the weight circumference of 91 centimeter, and her random blood glucose was 6.3 millimoles per liter. On a systemic examination, the heart center was normal, and the examination of the cranial nerve, the olfactory could identify smell in both nostrils, and her optic nerve on visual acuity of the left eye, she can perceive light. On the right eye, she can count fingers. On the visual field of the left eye, it was not accessed, but on the right eye there was temporal hemianopsia. And optic nerve still examination, the pupils are round and unequal, and the size being 8 millimeters of the one on the left, and the one on the right being 5 millimeters. The papillary reflexes beginning with direct afferent papillary. The left eye, the response was sluggish, but on the right eye, the response was just brisk. And on consensual afferent papillary response, on the left eye, it constricts well, but on right eye, it constricts sluggishly. And on relative afferent papillary reflex of the left eye, there was just it was just dilate paradoxically, and meanwhile to the right eye, it was just a normal constriction. On fundoscopy, there was a bilateral optic pallor, more on the left eye with sharp margins and no capping, together with retinal vessels were normal. Other cranial nerves were normal. Motor and sensory exam happens to be normal, and the remaining systemic examination was normal. Apart from respiratory, she just had tachypnea. The rest, it is keeping with normal. So this is the physical examination, past medical history of this patient, Joseph. You are welcome again. I
Yeah.
think you are able to cut up some stuffs here. So let's continue with your clinical pairs.
Yeah, thank you very much. So the history of hypertension is important in this patient, whom we suspected things which are occurring quickly. Maybe she has a stroke, probably, or a ruptured aneurysm, which you have if you have hypertension increases the chance of it rupturing. But the hypertension is controlled. So let's see the exam, which I think, to be honest, to be hard to dissect, but I will try to my best level. So yeah, let's see the neuro exams. I think that was head findings. Yeah. So yeah, the optic nerve. Let's start with this optic nerve. Um, so what we are seeing here is what is being described in the history, that this patient uh, lost his vision, like on the left and right, left more affected than the light. And then what we're seeing on the left eye, for example, the visual acuity only perceives light, and the visual fields, which is not assessed on the on the left eye, because patient can't perceive light, which is okay. But on the right eye, also paired vision, but visual fields is called temporal hemianopsia. And so let me try to think what is this. Hemianopsia is you are not seeing half of half of the brain. So temporal is, I think, outside of your eye. That is the temporal. I think the other is nasal. So the left eye is gone, but on the right eye, slightly gone. But what you can see, the patients can see on one part of the world, on outside of the world. What does that mean? It in any neuro exam, the right, like a patient who has a stroke and they can't use the right side of the body, it means the stroke sits in the left side of the brain. So it's the same in the eyes. If the patient can't see outside, like on the temporal part of the world. For example, this is the right eye, so they can't see on the right side of the world. It means this problem sits in the left side of the brain. The problem of okay, sorry. So this will be different. So that's what you should do, but this will be complicated because we're not being told we are not being told of the visual field exam of the left eye. Is hard to do it. You can't do it because patient can't see. But what I was trying to teach here is that if you have a patient whose both eye can see and they're saying they can't see one part of the world, what you should think is that the problem lies on the other parts of the brain. That's one. So here we can't know about that because the left eye can't see the world at all. The other possibility, if this left eye was functioning and also had hemianopsia on the same side, you would have, as I have said, would have said the problem is on the part of the brain that is not seeing the world. The other possibility that the right eye can't see the temporal part and the left eye can't see the temporal part. So you have like bitemporal, both sides you can't see on the temporal part of the world. And the problem in that category is localized, I think, on the chiasm. So as you know, the optic nerves, it crosses on the chiasm below the pituitary. So when there is something there like a pituitary adenoma compressing it, that's what patients present with. They have the right eye doesn't see outside, the left eye doesn't see outside. So this is among that. If we had the left eye seeing, so I'll keep that. I'll keep that thing that maybe one side of the brain is affected, and this has to be the left brain, or is the problem of the chiasm where the optic nerves crosses. And but if the problem just sat on the one side of the brain, we would have seen other symptoms on the other part of the body, but not necessarily. So we'll go with that. And let's see other findings. Yeah. So these are the reflexes, and if you know what these mean, until you know what these mean, you will be able to interpret these findings. So let's start with this reflex and the direct afferent pupillary response, sluggish on the left, uh, which means it's affected. So light doesn't even go in. Light doesn't even go in proper in this eye. So we expect this sluggish response. And but when we are told that on the consensual afferent pupillary response, um, which means I think if I'm mistaken, just hit me. The consensual, I think, is that you are examining the left eye, but you are lightening your torch on the right eye and seeing what happens with the left pupil. So what it tells you is that uh, the information from the brain is coming properly in the left eye, which is happening here. So the left eye doesn't take in light, but the information when it goes to the midbrain comes back properly in that pupil. On the right eye, brisk response meaning kwamba the light goes in properly, but when you light the torch on the left eye and look at the right eye, it goes sluggish because light doesn't goes in properly in the left eye. So there is a problem with light going from outside into the left eye. What I am taking from this relative afferent pupil reflex, I think this will be hard for me. I think this will be hard for me to learn through this presentation, but I think I can take this and conclude that the problem is the left eye taking in light. Uh, the eye takes in light, sends it to the optic nerve to the midbrain, comes back into both eyes, causes pupillary reflexes, so it doesn't go in properly. Either there's a problem with the globe of the eye or the cranial nerves number two, the cranial nerve number two itself. Yeah, but not the midbrain, because the midbrain, if it's affected, then it couldn't interpret the information. The coming back of the information would be also affected. Yeah, so maybe the problem is sitting in the retina, maybe, or is sitting in the maybe sitting in the optic nerve of the left eye. Uh, what I'm taking from this exam also is that I hear there is a swelling of the eye in the history, but it seems we're not seeing it here. So that is a bit more helpful. But I think I'll be thinking of it. Where did it go? What happened? Things like that. Let's proceed and see other part of the exam. Yeah, so here's the fundoscopy. Pretty new things I'm discussing today, and I think I don't know if I'm getting them right. So don't take much of the things I say. Just check me on your Google also if you think I'm saying things which don't make sense. So we're told that there is bilateral optic disc pallor more on the left eye with sharp margins but no coupling. The no vessels normal. So optic disc pallor, uh, the optic disc. I think this is the place where the optic nerve enters the retina. Like it's the place that the enters the retina. So if it's pale, yeah, I think what happened is it inflamed or is it infected, things like that. But all in all, the optic nerve of the cranial nerve, now the optic nerve of the left eye is affected through all these that we're seeing here. Uh, Other cranial nerves being normal, and then the motor and sensory exam being normal, says maybe you're not dealing with the motor system. Maybe we are, whatever the problem is sitting in anywhere in the brain, maybe it can't be in the motor pathway. Yeah, Seba, Lauren, let's see another exam. Okay, I think the exam is done. So let me conclude maybe from this. Um, I think we had a patient who had a thunderclap headache, and then they lost their vision, and the exam is just it's just the ophthalmological exam that is abnormal, and I think it represents um, it, it does represent the optic nerve being affected, optic nerve of the left eye being affected, um, uh, versus something which is sitting in the optic chiasm. So how to connect these two? I think it would be so hard for me. If I said, if I say one thing, maybe if I say this is a this is the for the most common cause of thunderclap headache, which I said subarachnoid hemorrhage plus or vis-a-vis CVS, for example. And then I say, can it be subarachnoid hemorrhage from rupture of an aneurysm? That aneurysm could have been sitting in the could have been sitting um, in the chiasm. Oh, less likely. But another thing is, how about um, how about the fact that maybe this patient had a, a tumor, a slowly growing tumor on the pituitary, and what we are seeing now is that this tumor has bled and cause infarction, what we call the pituitary apoplexy. That also is possible, but pituitary apoplexy, I think, shouldn't cause thunderclap headache. The way I'm thinking of it. So yeah, Seba, I mean, Lauren, sorry. Let's proceed. I'm not making any progress so far, I think.
Okay, Joseph. So far, you have already started touching the nerve. Actually, you are touching the what you are touching the area which is actually itching, and you're progressing well. So thank you. So, these were the results done. I think they are well reflected at your side. I won't go through them because of time, but this was the full body picture of our patient. Basically, it's normal, and these are the inflammatory markers, the estimated sedimentation rate, and the CRP were still at normal. The D-dimer was a bit raised, as you can see it here. And these are the renal function test and the electrolytes. The three most important being sodium chloride together with potassium. You can see they are still at normal. And the liver enzyme and synthetic functions, you can appreciate them there. Then this patient also did glycated hemoglobin together with fasting blood glucose. They were a bit elevated, as you can see here. So I think you are picking something here on his hemoglobin, on his serum blood glucose level. Then the lipid profile of our patient, there were derangement, the LDL being high, triglyceride together with total cholesterol being high, but the HDL being low, and the serology, HIV together with the VDRL, they were all negative. The hormonal profile now, this is how it's looking, Joseph. So I think you can note these findings. The TSH, free T4, prolactin, cortisol, the morning cortisol together with FSH and luteinizing hormone, they are all raw. And this patient, it happened that she did MRI, and this is what you can see from the MRI. I think you can appreciate where the deformity is. Right here, I cannot access the summary of the findings, but I think if I go to the next image, you'll be able to see, I think, on this image is that there is mass at the cellar to Sika. Um, yes, and that mass is visible over there. You can see, and this is what this mass has done. So up to this point, Joseph, anything that you have to share, you're warmly welcome.
Yeah, yeah, tough case. I can tell. So I think we shouldn't discuss this is normal. The abnormality, important stuff. ESR therapy were normal, and I just touched. I said any new headache in an elderly patient, especially if there is a loss of vision, just think of a GCA. But in GCA, usually, not always, but usually, ESR therapy are usually raised, and if they are not, which makes this disease here because we don't do the temporal artery biopsy, so we depend on this. If they are normal, just try steroid in patient. I do that, and then maybe they don't respond. You're just wondering, should I raise the steroid? So these were normal, maybe, and doesn't keep the history with GCA. So let's see the other. I think the hormones were interesting. There was a A1C 6.1. This is a pre-diabetes. D-dimer being raised doesn't do anything for me in this. So there was a slide for hormones. That was interesting. Um, yeah, yeah. This one is interesting. So I'll start with the prolactin. Is with a very good reasons. So we are told a prolactin is like a TSH to the thyroid. A prolactin to a pituitary is like a TSH to the thyroid. So a prolactin low like this, it points you that there is something to the pituitary. And then others are also keeping with it. Everything coming from the pituitary is also low. FSH, LH, cortisol, prolactin itself, the TSH and T4, a TSH, if you have a low T4 in the peripheral of your body, we expect you maybe to have a high TSH. But if you have a normal TSH, so you say maybe this is a secondary hypothyroidism, which is the problem of the pituitary. So yeah, if you see this, you just do imaging because this has to be coming from the pituitary. Something is compressing the pituitary, is not producing enough hormones. And then another interesting thing, I think, is the imaging that is showing the pituitary. I wish I had the finding, the radiology imaging, but I can try. Let's see the imaging, Roland. Yeah, here it is. I think this can enlarge pituitary, but in a T1 weighted imaging, and we are seeing the pituitary nicely labeled there, but on the posterior part of the pituitary, there is I think that a hyper dense thing. I think things which happens suddenly, they are bleeding, and maybe it isn't keeping up with the this is blood, they say, uh, the pituitary bled. Yeah, so is this that I was talking about? Maybe this patient had a pituitary tumor, which caused all those hormonal changes, caused minimal headache over time, and over the past 2 months, the headache is that the the tumor has bled, pituitary apoplexy. And once that happens, under that pituitary, there is a chiasm where the optic nerve crosses, and maybe one of the optic nerve being the left optic nerve being compressed, loses vision. After losing vision is what you see as pallor on fundoscopy. So maybe everything start making sense now. Do we have other slides, or?
No, Joseph. So I think from this juncture, I would want you now to summarize maybe for somebody who came late and where have you come from and where have we gotten at, because the next slide here is for you maybe to commit to a final diagnosis, and then from there we'll have a few teaching points, and then we can call it a day. So maybe for to the advantages for people who are not here from the beginning, you can just give them a summary and how far have we narrowed our differentials up to this juncture. Welcome, Chief.
Thank you very much. This is the case that I think it is was hard for me. It was started with neuro case and then turns out into some stuff about ophthalmology. Ophthalmology in other countries is part of neurology, neuro ophthalmology, but around here maybe usually not. So that's why it was difficult to detangle some information. So this was a case of an elderly female who had low intensity headaches over 2.5 years. And then 2 months ago, they had a thundercrap headache, a severe headache worst of their lives, which peaked within, I think, a minute, um, uh, which was then followed by loss of vision starting in the left eye and then gone to the right eye. The right eye went back to normal. Um, no any other systemic symptoms known to have hypertension, dyslipidemia. The exam findings, general exam normal. I think the most important thing were on the neuro exam and on the visual, which I interpreted as there is a optic left optic nerve neuropathy, and plus there was pallor on the when they did the exam of the eye. Yeah, motor exam just normal, and what we saw on the labs of importance is every hormone is down, every hormone produced by the pituitary is down, and the imaging, I think, no report, but I think that was a pituitary tumor that has bled, and I think my final diagnosis is pituitary apoplexy.
Okay, thank you, Joseph. But also, I would like you to give some comments. Let me take you back somewhere. Can you think of something else out of this patient glycated hemoglobin, maybe? But then again, if you remember, I also gave you also on part of physical examination about the BMI of this patient. Then I think from there now you can maybe you can sum up all the differentials and the differential diagnosis that you are having. Then I will reveal to you the diagnosis and we can have a discussion. Thank you, Chief. You are warmly welcome. If you can sum up maybe other findings that you still also want to put in this bucket of our patient, then we can have the final diagnosis revealed. Thank you.
Um, yeah, so the this BMI patient is obese. Obesity is so common around here, but I'm not seeing anything that is saying I should consider maybe the obesity of this patient. For example, in a patient who is obese and you see central obesity, strias, buffalo hump, you can think of maybe a Cushing, but that's not the case here. And what I'm seeing is that obesity and A1C 6.1, also not surprising, pre-diabetes in an obese patient. Unless, Roland, I'm missing something that you want me to talk about and I'm not.
Slide also.
Hmm?
There's something also lying from this slide. Can you see it?
Um, yeah, so what I'm seeing here is that everything is elevated, like the total cholesterol, trig, LDL, and then the HDL. So, yeah, so this is a dyslipidemia. Um, I'm not saying as if there is an abnormal from what I'm seeing in being common around in patients who are obese, hypertensive, diabetes or pre-diabetes.
Okay, so thank you, Dr. Joseph, for a very nice discussion. So
The
let
thing
me,
is,
yes.
wait a bit. The thing is, does anyone have a report on that MRI? Because I'm not a radiologist. I think the diagnosis have to come from that MRI, and I said I think it's a pituitary apoplexy. A pituitary tumor is a pituitary apoplexy, and maybe there's something else if that MRI showed anything different from that.
From the this patient's MRI, let me go back to that image. Let me go back to that image. The conclusion of this MRI is that there was a mass at the cell in keeping with pituitary microadenoma. So, as Joseph, you have said, that was the report from the radiological finding of this MRI, and the final diagnosis. Would you want to reveal maybe, or I can just continue from here?
Yeah, continue. Mine is a pituitary tumor with a pituitary apoplexy.
Okay, thank you. So the final diagnosis to our patient happens to be a pituitary microadenoma complicated by pituitary apoplexy with panhypopituitarism and compressive optic neuropathy. So it was an intertwine of endo, neuro together with ophthalmology in here. That also, as I was stressing up to the BMI of this patient, to the serum glucose of this patient, and together with the dyslipidemia. So also this patient is having a metabolic syndrome. So the next slide here, as you said, Joseph, after the imaging, what else can somebody do? So which other investigation maybe would you like to do? Either you want still to query where is this how is the pituitary is there an infection really, is there a hemorrhage really, is there a tumor, any other investigation that you would think you can do to this patient before I bring out the teaching points?
Yeah, so I think when I read around in up to date, there is when they talk about pituitary things on the pituitary, there is a special imaging. They say MRI pituitary protocol, something like that. But in a patient like this who had a severe headache, like a thunderclap headache, you should also do an angio.
Thank you. So the next slide here, let me project it. Sorry, 1 minute. Yes. Histology of this patient, it revealed that this patient had histology examination showed stained section showing neural tissue with the central part of an old hemorrhage, as you can see it evidently here. So this neural tissue, and this is an old, very, very old hemorrhage. But also, again, this histology again, the section shows a hypercellular and hyperchromic tumor, um, which is composed of relatively epithelioids and no pleomorphism and atypical mitosis. So this was histology done to this patient, and yeah, as you can see again here, there are tumor cells, um, there, and the biopsy revealed a pituitary adenoma. So since we are out of time, let me just take you through the teaching point, and then we can later have a reflection on this case. So learning point, pituitary hypoplexy, as Dr. Joseph got it right, is a rare, but it's a very, very life-threatening endocrine emergency. This clinical syndrome is caused by hemorrhage or an infection of the pituitary gland. So as Joseph, as it began to make sense to Joseph earlier, that the patient began with headache, then later optic issues. It means that there is something wrong happening somewhere in the brain. Then either there is a compression or something like that. So may cause several hormonal and neurothermic complications with fatality. So it needs prompt diagnosis, multidisciplinary management, as we have seen there. We need a histopathologist. We needed the radiologist and the other people. Um, to be able to manage this patient and also to be able to make a long-term follow-up for this patient. So the prevalence of pituitary apoplexy is somewhere between 1.5% to 10% of patients with pituitary adenomas, and it affects more females than males, and the peak age being between somewhere from the fifth decade to sixth decade of life, and the precipitating factors being hypotension or shock, as Dr. Joseph said earlier, that a patient might come with massive hemorrhage from obstetrics history there, then at some point may present with similar presentations, headache, and that one we all know that is Sheehan syndrome. Also, hypertension is responsible for that. Major surgery such as coronary artery bypass graft, coagulopathies, they can also cause that. So this is a very, very busy junction, and I think that's where the problem began. You are having the pituitary gland seated over here. Then also here there are cables, or we can call it's an optic chiasm, where now the optic nerve actually is passing here. So any compression right here, any bleeding right here, any infection right here, it has potential to affect. It has potential to affect the visual field of this patient, as we have seen for this patient had bilateral hemianopsia. So the pathogenesis and the clinical presentation of pituitary apoplexy. Um, for example, let's take just to a patient who is having a pituitary disease, such as our patient who had a mass seated over there, an adenoma. So as it grew, as it keep on growing up, it got a moment where it burst. So there was intratumoral or intralesional hemorrhage. Then this is what the co-event is what we call now the pituitary hemorrhage. That means there is blood gushing out. This blood, it can lead to increased intracranial pressure. By increasing intracranial pressure, that means it's going to compress the optic, hence the cranial nerve involvement that our patient also presented. But then again, remember, there is a gland seated over there. So there's going to be pituitary parenchyma or injury. Now, what symptom did our patient present? The pituitary apoplexy. When there was a rise of intracranial pressure due to the bleeding, our patient presented with headache. I remember earlier, Joseph said the hemorrhage, it can cause somebody to have a thunderclap headache. So our patient had headache. Other symptoms, they were not there. But on a cranial nerve involvement, CC, due to hemorrhage and increased intracranial pressure, there will be a compression. So as the optic nerve is compressed, there will be reduced visual acuity and visual fields and ocular paralysis. But also pituitary parenchymal injury will lead to hypopituitarism. To another phenomenon, for example, to patients with shock or patients with severe hypotension, patient may undergo postpartum pituitary necrosis. Then this will lead to pituitary parenchymal injury, then later to hypothyroidism. So diagnosis, MRI is very sensitive, and it's an investigation of choice, since it has the sensitivity of 90%. However, CT scan can be done, but it's used in emergency and acute setting. However, between CT scan and MRI, CT scan is commonly available. CT scan can also be done when MRI is contraindicated, and however, the sensitivity is still low comparing to MRI. And other investigation one can do, you can check the pituitary function, and it will be characterized with hypopituitarism. Growth hormone will be low, gonadotropin deficient by about 75%, corticotropin deficiency, thyroid deficiency, hypo hypoprolactinemia, together with other tests. However, to our patient, as we did, There was no hypotremia. The renals were just normal, together with the full blood picture. And now, how are we going to treat or manage this patient? Phase one, we want to stabilize, to support measures to ensure hemodynamic instability if this patient had hypotension or shock. Then assessment of fluid and electrolyte balance, Then you consider hydrocortisone replacement. After we have stabilized our patient, the next phase now will be to do investigations. As we have said, it's touching a lot of specialties, um, um, full blood picture, electrolyte, pituitary functions, they are all important. Imaging is also very, very important. But after we have done all our investigation, then a multidisciplinary team can come to a table now to discuss. It might involve endocrinology or neurosurgery. And immediate after the diagnosis has been confirmed, we are going to triage this patient. Either he can be to the arm of surgical consideration or the arm of conservative management. To the patient who fits for surgical consideration are those with severely reduced visual acuity. But if patient has deterioration of level of consciousness, that means the prognosis is very poor, and we cannot put this patient to surgery. The patient now, how the textbook say we should manage this patient, we should do hormonal replacement therapy in panhypopituitarism, since all the pituitary hormones in here they are low. So we are going to supplement them with hydrocortisone, levothyroxine, sex steroids, and growth hormone. Also, somebody has to put them into lifelong monitoring and patient education on sick day rules to prevent adrenal crisis. I think we are all aware of those three steps to do on sick day rules. So if a patient, for example, he doesn't, he's just presenting with fever, so you can tell them they can double their dose and stuff like that. So what was done to our patient? So our patient was kept on prednisolone 5 a.m., 5 milligram at a.m. and 2.5 in the p.m., levothyroxine, rosuvastatin, and metformin together with antihypertensive. So it's time now to reflect. Joseph and anyone, or I would like to first recall Joseph for any reflection on our patient. Then, if anybody will have a point to share, experience or a question, I think this is going to be the moment. Welcome, Joseph.
Thank you very much, Roland. Nicely presented. Although you didn't see this patient, but the way you're presenting, like you saw the patient. And for my part, I think it has exposed my weak. I had a schema. I've read this thing that I recognize that this is a thundercrap headache, and then completely forgot that now what I should have. What are the DDX except the common one. So let me show you something here quickly. This is the when I read this, I wrote some notes here. I think can you see this?
Yes,
Can you see
visible.
this one?
Yes.
Yeah. So this is the thundercrap headache. You have to have this because when it happens and you're in a hospital, you pull this up, you see because so I've seen it. I've seen a thundercrap headache. They're so stressful. Relatives, the patient is crying. Things are weird. But if you have now this, you can like the definition of this doesn't this patient. And then I remember the common one here, and then I forgot completely around here. These so many, and turns out on the parenchymal part there is pituitary apoplexy, meningoencephalitis, etc. So maybe also keep this in mind. Thank you very much, Roland. I think we are out of time. I shouldn't say much. And I looked at the chart. Antimon got it right even before me. I should have looked. Maybe couldn't have struggled. Thank you very much, Antimon.
Okay, thank you, Dr. Joseph. So, Dr. David, if you have anything together with Dr. Antimon, you can also share your experience. So this is the moment. I think though we are past the hour with some few minutes, but I think we can spare some few minutes to be able to grasp some stuff from you. You're welcome, David.
Yeah, thank you very much, Roland, for presenting the case. So, Antimon, if you are there, can you please share your experience? Because Joseph, if you can remember, I think Antimon presented a case. So sad that Antimon cannot unmute, but he presented a case of pituitary apoplexy when we were residents in a grand round. So that just underscores the importance of being exposed to a number of cases. So you attend a case, you exposed in a way like this. Uh, you have listened attentively through this hour, and then you see a case like this. It's just pattern recognition. You will not need to do a lot of thinking. So I think. That is what contributed to the ease with which Antimon made this diagnosis after hearing a few clues. Yeah, so thank you very much, Antimon, and I see there were some other differentials from Michael and Mashauri talking of neuromyelitis optica and Mogad, and I think this was based on the visual loss. So Michael, if you are there, and Thomas, if any of you would like to share on what were your thoughts that made you consider those differentials, please welcome if you're in a position to speak. Michael and Thomas, I'm not sure if they yeah, I see Mashauri is still in the chat. I'm not sure about Kisoka. So if you're in a position to speak, you can just unmute and speak. But otherwise, Roland, thank you very much for the case, for presenting the case, and Joseph for the lots of teaching points. I'm not seeing any hands or anyone unmuting to speak, and we are beyond time. So thank you very much, everyone, for joining. And so, Joseph, I just want to give you some good news. So Mudhihir reached out to me. So Mudhihir is a third year resident now at Muhas in internal medicine. He reached out to me and said he has a case to share. And because we had already said Seba would present another case today, so we had to finish that. But so hopefully next week, Mudhihir will be here to present a case to Joseph. So I'll let Joseph continue having the fun for a third week, I believe. So uh, thank you very much, Mudhihir, for volunteering and your willingness to share interesting cases that you see. So I know that others are also seeing interesting cases, but maybe you are second guessing either you're good enough for AfroDX. We need to learn from all kinds of cases. So please bring those cases. So for everyone who attended, make sure not to miss next weekend, because we'll have a breath of fresh air from Mudhihir presenting a case. And make sure also to inform others who are not here to make sure they do not miss next weekend. So otherwise, thank you very much for joining, and have a good night. See you next weekend.